Hello and welcome to Addressing the COVID-19 Crisis, our weekly open forum series for pharmacists. This is Michael Hogue, the Dean of Loma Linda University School of Pharmacy and the President of the American Pharmacists Association. We are so happy that you have joined us this week for what is going to once again be an exciting program. We are very, very attuned to the fact that COVID vaccine is coming. We've heard a lot about it in the news lately, and pharmacists have taken such a prominent role in vaccination campaigns across the lifespan. We thought it would be very good to help update pharmacists today on what our role might be in COVID vaccine safety monitoring and the COVID-19 vaccine clinical trial process. There's not been a lot of press about what pharmacists might need to be doing as it relates to post-marketing surveillance and as it relates to the trials that are ongoing, and there are a lot of them going on. Now, today we've got the experts in the field about these topics. We are very delighted to have with us from the Centers for Disease Control and Prevention, the Deputy Director of Immunization Safety, Dr. Tom Shimabukuro, and he will be with us to discuss how the CDC approaches vaccine safety, and I think you'll find this to be a very enlightening discussion. We're also very excited to have with us today Dr. Jim Kublin, who is the Executive Director of the COVID-19 Prevention Network and the HIV Vaccine Trials Network at the Fred Hutchinson Cancer Research Center. Now, Dr. Kublin is, as you will hear, really developing national registries of individuals who are interested in being a part of these vaccine trials for COVID-19. And so we're going to hear firsthand from him about all the things that go into these trials and safety and so forth. As we do every week, we have experts from APhA staff who join us, and as our webinar progresses, you'll have the opportunity to ask questions about anything related to COVID-19, not just the vaccines. And when you have questions that are about drug therapies, our own Dan Zlot from APhA will be answering those questions. He's Senior Vice President of Education and Business Development and spent 10 years at NIH working in the cancer research and immunology area. And also Mike Baxter, our Senior Director of Regulatory Policy at APhA, is going to be sharing with you two pieces of late breaking news. One that came in the news yesterday that likely many of you have heard about relative to pediatric immunizations, and one that is just broken this morning, actually, before our webinar started, relative to testing. And so we're going to allow a little extra time today during our webinar to answer questions about those two issues. So you won't want to miss that toward the end of the webinar today. Now let me go over some logistics for those of you who might be joining us for the first time. We have a lot of folks who I know join us weekly, and we're happy to have you here week after week, and thank you for your support. For those who are joining for the first time, the way this works is that I'll interview each of our speakers, and today I'm going to do that individually first because they come from pretty different perspectives, and then we'll bring them both on at the same time, and you'll be able to ask your questions. Now, the way that you'll do that is as you have questions, there is a question box in the GoToWebinar control panel. We ask that you just type your question into that question panel, and then when it comes time for us to open up for questions, we'll call on you and unmute your line so that you can ask your question verbally. Now, if you're connected through computer audio, that's pretty easy. We just unmute your line and you click on the microphone icon, and that's it, and you can ask your question. If you're joining us with a cell phone or a landline, then you have to enter into GoToMeeting an audio pin in order for you to be able to be unmuted so that you can ask your question. I would encourage you to go ahead and enter your audio pin number now so that you can be unmuted later. And if you don't have audio capabilities, no sweat. You can still ask your question, put it in the GoTo questions. I'll ask your question on your behalf. Just put in there no audio, and then I'll know that I need to ask the question on your behalf. The handouts for today's program are found in the handout tab. You can download those. All the links that are in the handout are active and will take you to web pages where you can find more information. And our speakers today have provided additional material at the end of the handout that we won't be covering during the slide presentation, but that you may find informational in the future and going forward, so you can access those at your leisure. Also, today's webinar is being recorded and will be available at pharmacists.com in the COVID-19 resources section. We believe that you'll want to share this program in particular with a lot of your colleagues, because we're going to talk about vaccine safety, and I think this is something that every pharmacist really needs to hear. So with that, I am going to invite Tom to join me, and we're going to have a conversation now a little bit about the CDC. So Tom, thanks for joining us. I'm not sure if you're able to join via video or if you're going to be with us in audio. Are you there, Tom?
I'm here. Can you hear me?
I can hear you. Great. Thanks so much for being with us. Really appreciate it.
My pleasure. I'm going to have to join in audio today. I'm sorry about
That's
that.
great. No problems. Okay, what differences are you anticipating with the launch of COVID-19 vaccine compared to other vaccines? Are there differences?
Well, it's possible that the vaccine, when it initially comes out, may be authorized under emergency use authorization and available in very limited quantities. And a short period after that time, hopefully, may be available in large quantities and available to anyone who wishes to get vaccinated. I think probably one of the big differences is there's going to be a lot of visibility on vaccine safety, a lot of concern on vaccine safety, and high expectations that we monitor vaccine safety very closely. And if there are safety problems that we detect in the post-marketing phase, that we quickly assess those and address those and take action if need be.
So what you're saying is that there is going to be, in your opinion, a much higher level of scrutiny and an approach by the CDC that might be a little different related to safety monitoring for COVID vaccines. At least the expectation is going to be different.
I think that's a fair statement. I mean, if you're familiar with the role and the activities of Operation Warp Speed, one of the things they've been trying to do is to compress the normal vaccine development and delivery timeline. And the development in the clinical trials and the evaluation, that is going along as normally would. It's just that the timeline, which usually takes years to decades, is being compressed into a period of months. And because of that, I think there is a higher level of scrutiny on the safety and even the efficacy of the vaccine. And we are going to conduct what we call enhanced monitoring, which means looking at a lot of different outcomes, using different systems, and being much more vigilant. And if you're around for H1N1, it's going to be a similar situation to H1N1, but I anticipate there will be as much, if not more, scrutiny on vaccine safety.
So could you provide a brief overview to our pharmacists about post-marketing surveillance and adverse event reporting for vaccines? And in fact, I think we might have a slide or two here to just kind of talk about this.
Sure. So this is the vaccine life cycle, and although it's somewhat different for COVID vaccines, I think the general principles apply. You know, there's basic research, discovery, preclinical studies. If those are successful, we move into the phased clinical trials, and you may be aware that some of the candidate vaccines are already in phase 3. If those are successful, there's an FDA review, and normally that's a biologics license application submission and an FDA licensure. In the case of COVID, it may be an authorization under emergency use authorization, which doesn't preclude a licensure sometime in the future. Typically, shortly after approval, there's a review by the Advisory Committee of Immunization Practice, and then we move into the phase 4, or post-licensure, post-marketing period, where we continue to monitor for vaccine safety. You may be asking yourself, Well, why do we do that? Isn't the vaccine safe and effective? Well, the safety standards for vaccines are very high. These are for prevention, not for treatment of individuals that have illness. They're generally given to healthy people, people who don't at least have the illness in which you're vaccinating for. And the pre-licensure trials are not necessarily designed because of numbers to detect very rare adverse events or to monitor vaccine safety in the real world. And that's why we do vaccine safety monitoring. There are basically two different ways we monitor vaccine. One is through spontaneous reporting or passive surveillance, and I can discuss that more in depth. And the other is through active surveillance, which is primarily electronic health record surveillance in large length databases like claims or administrative databases. And Michael, would you like me to talk a little more about VAERS and
Yeah,
passive surveillance?
I would like you to do that. But before we go into VAERS, could you just share with us what does CDC consider to be an adverse event? So, I mean, pharmacists see lots of things, related to medications, and we deal with medication adverse event reporting. Obviously, we do that pretty frequently. But with vaccines, are we talking about a sore arm as something that needs to be reported, or are we talking about something more serious than that pharmacists need to be paying attention to? Can you just kind of give us a little bit of an understanding of what you're hoping in post-marketing surveillance to be able to discover or uncover or find as it relates to adverse events?
Sure. I think the clinical trials, and especially the clinical trials for COVID vaccine, which are going to be pretty large, around 30,000, they're good at detecting and characterizing common and what we consider expected adverse reactions, things like pain at the injection site, systemic reactions like fever, muscles aches, fatigue. Um, the when we do post-licensure surveillance, we are actually more focused on clinically serious or clinically important adverse events. Important is a little bit difficult to define. Sometimes that depends on the clinician judgment. But the definition of an adverse event, and you see the timeline here, is a person gets vaccinated. At some point in the future, they have an adverse health event. The time between vaccination and the onset is called the onset interval. These adverse health events can be true reactions, true adverse reactions that are causally associated, or they can be coincidental health events and not related to vaccination. One of the things we obviously try to do in vaccine safety monitoring is to tease out what's a true adverse reaction between what's a coincidental health event. And for the purposes of the vaccine adverse event reporting system, our national passive surveillance system, reports are adverse events where there's a vaccination, an adverse health event, and then they get reported to VAERS. So if you think about what's actually in VAERS, it's a partial numerator system only. If you think about the fraction, if you want to do a rate, you have to have events over exposure. We have partial information on the events and no information on the exposure. And in VAERS, we're really looking for unusual or unexpected patterns, which we call safety signals.
So Tom, is it necessary for a pharmacist to figure out if an adverse reaction or an adverse event that's occurred was caused by the vaccine? Is it the pharmacist's responsibility to figure out if the vaccine caused the event, or is it simply important that the pharmacist report that, hey, we gave a vaccine, this event happened, we don't know if it was the vaccine or not, and we need to report it? What is the responsibility of the pharmacist to determine causality?
So we encourage the reporting of any clinically important adverse event following immunization, regardless of whether the healthcare provider suspects or knows that there's a causal association. So we encourage reporting for any clinically significant or clinically important adverse health event, regardless of whether the healthcare provider has made a determination on whether it's causally associated or not. There is really no drawback to reporting adverse events. In fact, we encourage this We have techniques where we go through and look at data mining and do disproportional reporting. We don't consider it the job of the healthcare provider to make an evaluation on causality and make that a criteria for reporting. We want any clinically important adverse event following immunization to be reported to VAERS.
Okay. Well, now getting to VAERS, I think on the next slide, maybe you could just go over with us what is VAERS? What
Sure.
is this?
VAERS stands for the Vaccine Adverse Event Reporting System. It's been in place since about 1990, is authorized by law, and it is co-managed by CDC and FDA. It's a spontaneous reporting or passive surveillance system. So we rely on the public and the manufacturers to send us reports, and we accept all reports from any reporter. That can be a parent, a patient, a healthcare provider, of which pharmacists are, of course, a caregiver, and manufacturers are required by law to report any adverse event that comes to their attention. We accept all these reports without making judgment on causality or without judging clinical seriousness of the event. And it's a hypothesis generating system to identify safety signals, which are unusual or unexpected patterns or disproportional reporting that we would then go study in more robust systems.
Yeah, and I think it's important for our audience to know that completing a VAERS report does not somehow come back to penalize you as a healthcare provider. So it's not a gotcha sort of system. It's not as though you've done something wrong and you're going to wind up being penalized or sued because a vaccine caused a reaction. This is just simply a safety system, and it's intended for the good of public health. Am I summarizing that correctly, Tom?
That is correct. I mean, this is a public health surveillance system. It's not used in any legal way, although I will say a person can request their own VAERS report or that person's representative. But if kind of moving into the issue of liability, which isn't really in CDC's lane, but I will mention that all routinely recommended childhood immunizations are covered by the National Childhood Vaccine Injury Act, which basically indemnifies healthcare providers that give vaccines, because there is a no-fault system for compensating people who believe they have been injured by vaccines. There's also a parallel program called the Countermeasure Injury Compensation Program, which comes into play for public health emergencies. So there are mechanisms to basically indemnify and hold harmless the person administering the vaccine. And no, if submitting a report to VAERS does not put you at any legal risk as far as litigation.
Now, I think we've got a screenshot of the VAERS form. This is something that you complete online. Can you give our pharmacists listeners an idea? How long does it take to complete one of these forms? What's the time investment? And is there essential information? Does everything get prompted through? Just maybe give us a brief overview of this.
Sure. So what you're seeing here is a screenshot of the online reporting portal, where you can go in and directly submit a VAERS report by filling in these data fields. There's also a fillable PDF that you can download, which has the same fields, and you fill that out and then you upload it. There are certain essential elements that we think are essential, such as the patient's birth date or age, the actual vaccination, a description of the actual adverse event. We encourage the provider to be as complete as possible when filling this out, but we never stop you from submitting a VAERS report if you don't know the answer to these fields, even the ones that we consider essential. The time it takes to submit a VAERS report probably depends on the kind of event. The more serious and complicated, probably the longer it takes. But we've done a little bit of testing ourselves, and we think on average it probably takes about 10 or 15 minutes to submit a typical VAERS report.
So just real quickly, I'm going to ask you just a couple more questions, and then I'm going to move on and speak to our other guest about our clinical trials work. But why do you think it is so important for pharmacists to be extra vigilant in reporting adverse events with COVID vaccine? Why is that important now? Maybe pharmacists haven't been as vigilant about it with flu vaccine or other vaccines.
Well, I think with more vaccination being given in pharmacies, and I think with pharmacies and pharmacists likely to play a bigger role or play a major role in immunizing the American public, I think that you're close to the patients, and you're also going to be administering a lot of vaccine, and it's an opportunity to, if you have any suspected adverse events, to send those to VAERS so CDC and FDA can monitor these. The more data we get in VAERS, the better we are able to characterize the basic safety profile of the vaccine. That's important for two reasons. If we do detect an adverse event, we want to take action. But if we, based on our assessment of the data, this vaccine looks similar to other vaccines in the other vaccines that are routinely administered, we can say, this vaccine appears to have a safety profile which is similar to what was identified in the clinical trials and similar to other vaccines that are administered to patients in specific age or risk groups. So I think the more data that you can provide us to CDC about the safety of this data, the better we can communicate to healthcare providers, to public health officials, and to the public about the safety of this vaccine.
Absolutely, absolutely. Well, I tell you, let's shift now to Dr. Jim Kublin. Dr. Kublin, I think you may have webcam access. Can we get you to turn your webcam on and join us? Thank you so much for being a part of our program today. Now, for our listeners, I just want to remind you that Dr. Kublin is doing some pretty exciting work as it relates to building the capacity for us to do more vaccine research with COVID. Dr. Kublin, just give us an overview of what you're working on. Tell us a little bit about what your project is related to COVID-19.
Thanks, Michael, and thanks to the American Pharmacists Association for bringing us together. So we are very excited about the developments in vaccinology that have enabled us to get to this point where we're now testing the efficacy of three different platforms of vaccine types with 5 different vaccine developers, and there are others as well in the pipeline. And these phase 3 efficacy trials are those studies that really can evaluate very thoroughly the efficacy of the vaccine, how well it can prevent a reduction in disease among those who get infected with this virus, and also, of course, to Tom's points, making sure that we have a very good handle on the safety of these vaccines as we expand them into these large clinical trials.
So could you just briefly walk us through the process of bringing a vaccine to market? What are the various studies? I think we saw this slide earlier, but from a safety perspective, just tell us on the clinical trial side, what are these phases and where are we?
Sure. So in the the yellow-orange area on the left of this cycle is all of the preclinical development activities that are typically taking years and years for a vaccine to get into the clinic. Fortunately, we're relying on platforms that have been developed over decades, if not centuries, to make vaccines. And I mentioned 3 platforms. One is a nucleic acid strategy, one is adenovirus vector strategies, and the third is the more traditional protein adjuvant platform. All 3 of these platforms are now reaching the critical milestones of passing the phase 1 safety studies. That typically involves double-digit numbers of volunteers who participate. The phase 2 trials are looking more at both safety and extensive immune responses. How well do these vaccines induce what we hypothesize hypothesized to be effective immune responses that would be protective. And then when we get into the phase 3 trial, that's when we're really ramping up the numbers. And as Tom mentioned, we'll be going into 30,000 individuals for each of these vaccine efficacy trials that will be launched throughout the fall. And within each of these efficacy trials, these phase 3 efficacy trials, they're randomized, double-blind, controlled clinical trials. We'll be looking at the vaccine and the placebo, and hopefully then by the end of the year, we'll have a signal as to whether or not there's a higher rate of disease among those who receive the placebo compared to the vaccine. And we won't know that until we unblind these studies. And that's what these critical phase 3 clinical trials will provide us, a signal of that efficacy, and of course, a much more comprehensive look of the safety of the vaccines, so that we can then deploy them to the millions of Americans who would naturally benefit from a safe and efficacious vaccine.
So I think that that's the big question that most pharmacists and other healthcare providers have in today's world. We see Operation Warp Speed obviously pushing vaccine manufacturers forward. We're seeing processes in place that are a little different than processes we've used. So, you know, how do we as healthcare providers have confidence that whatever vaccine does come to market really is safe? I mean, how can we have that confidence as providers? And then maybe you can speculate how we will be able to help our patients have that same confidence.
No, these are great questions, and ones that, you know, I'm asking myself as well. How can I be assured that these vaccines are sufficiently safe such that I'm promoting a registry where we intend millions of Americans to join us to volunteer for these clinical trials? I want to make sure that before we move into these phase 3 trials, the critical safety evaluation of the vaccines has been done and has been peer reviewed and thoroughly evaluated. Those steps have taken place for the one vaccine that we're working on in phase 3, the Moderna vaccine. That has been peer reviewed and published in the New England Journal of Medicine. There are adverse experiences associated with that vaccine, as well as these other vaccines, that are typical of vaccines that are very well licensed and out there in the public and used very efficiently. And those are typically, you know, soreness, tenderness, redness at the injection site, occasionally a general feeling of malaise or mild symptoms. These symptoms are the result of the vaccine activating the immune system, which is what we really want them to do. We're also confident that the dose of the vaccine is not too high so that it's making people unnecessarily sick or have more moderate or severe adverse events. These are really generally mild. And indeed, when we move into these 30,000 person efficacy trials, we'll have a much more precision about the rates of these adverse experiences that people will likely have when we deploy them into the general public. So that information will be available to the pharmacists. That information, of course, is available to the study participants themselves when they enroll in these clinical trials, and it is revealed to them typically in the consent form with what adverse experiences they may encounter. Of course, we're also drawing small amounts of blood in these late phase efficacy trials to identify what type of immune responses are most associated with that vaccine efficacy. And these critical correlates of protection can only be identified in the large efficacy trials. So being a participant in these efficacy trials, I think tremendous honor and civic responsibility that so many people in this country have demonstrated a willingness to participate in, but we need more.
Yeah, so that brings us to our next slide. And really, I think what's really critical for our audience to hear today is that Dr. Kublin is actually developing and maintaining the database of volunteers to serve as participants in these studies. And I'm pleased to report to you, Dr. Kublin, that I've already signed up and listed to be a part of the Army to be a part of these testing programs. And so maybe you could tell us a little bit about volunteering and what you're looking for in terms of numbers and so forth.
Well, thank you. And I'll give a big shout out to our teams, extensive teams across so many different groups who have helped develop this registry. It is at coronaviruspreventionnetwork.org or covpn.org. And we have materials for the pharmacists to distribute, promotional cards, materials that they could use. And when you go to that public site, we have a tremendous resource of background and information on the vaccines that are being tested, what it really entails to participate in these clinical trials, an FAQ page that has answered a tremendous amount of some hesitancy that people have perhaps to participate in these clinical trials and what to really expect. And so when they go into the Volunteer Now button on that public website, coronaviruspreventionnetwork.org or covpn.org, there are Volunteer Now buttons all over that website. And that takes you to a registry in which we collect the personal information from all individuals. It takes about 4 or 5 minutes. And what that provides us are the critical demographic factors, and you can see the Volunteer Now button there. The critical demographic factors, including age, which we're very concerned about, and type of occupation, residence, how many people you may live with, what type of commuting or behavioral aspects may increase your risk of exposure. And then at the end of the day, at the end of today, we'll have well over 350,000 people who have completed that registration, including yourself. And those individuals then are based on their zip code, are made available to the clinical trial sites enrolling into these studies. And I must say the principal investigators of these sites have said this is the best thing to help us in recruiting individuals into these clinical trials, because they can identify the critical ages and risk factors that are associated, as we know, with severity of disease, and also some of those factors that may increase an individual's risk of getting the infection in the first place. Yeah. So it's a really critical tool, and I think a civic duty for us to all join in on this registry.
It's great. Well, on the next slide, just to let our listeners know, APhA is very proud to be promoting the recruitment of volunteers to participate in this large database. If you go to pharmacists.com as a part of our COVID-19 resources, we've partnered with Dr. Kublin and the network to be able to provide posters that you can download, flyers that you can use in your pharmacy practices and in your clinics to encourage consumers to register and to be a part of the registry for these clinical trials. So we're very happy to be able to support this work, Dr. Kublin. We agree with you that it's important work, and by getting folks to participate, we move more rapidly to having vaccine available for our society. So we're excited about that. One last question I have for you before we open this up to our audience for questions. There's definitely a greater impact of COVID-19 on minority populations. We've seen this in study and analysis after analysis. and African American, Native American populations have been disproportionately hit with COVID. What are you doing on the clinical trial enrollment site to try to ensure that we have a great minority representation as a part of these registries? Are you taking any special efforts there to try to enroll minority populations?
No, thank you. That is a very high priority for us. Unfortunately, this epidemic is demonstrating these health inequities that exist in our society, and those disproportionately impacted are a very high priority for us to get into the registry. Now, one way, of course, to simply accomplish that is to make sure that we have the registry in both English and Spanish, because Hispanic, Latinx individuals are being so disproportionately impacted. So we do have a Spanish version of the website and of the registry to enable people to process and go through that. All of the FAQs, the entire site has been translated and is bilingual. Now, we don't have it in other languages. We also know that some other minorities are disproportionately impacted who speak different languages. We've helped translate materials into Marshallese, which I think was the first time that we had to do that for a domestic site. Other languages are being translated on a site-specific basis. And when it comes to other minority populations that we are trying to educate about this effort, we've got public service announcements that are coming up. We've tried to engage with sports franchises and the NBA and some of the players who themselves or their families have been devastatingly impacted by this. And then we have faith-based initiatives that are going to start in the next week or two. You're about to see, I think, a major national public service announcement and engagement effort that the CoVPN is undertaking, and very specifically to try to address the need to have these people participate. There are terrible histories of unethical medical research that has been targeted to minority populations. I'm very proud to stand here as an advocate of the work we're doing that tries our best to engage with all the communities, to do so in a very respectful and informative manner, providing research literacy on what it really means for individuals to participate, and then all of the information to be made as transparently possible, so that all Americans can feel informed and motivated to participate.
That's great. Now I've got an audience question. Tom, I know you're still with us via audio. Tom, I'm going to ask you this question. This is from one of our audience members. Do clinical trial vaccine adverse events have to be reported to VAERS, or should they be reported to VAERS? What's the link there between clinical trial vaccines, these phase 3 vaccines, and VAERS, or is there a link?
Typically, the safety monitoring requirements for pre-licensure clinical trials are laid out pretty clearly in the protocols, and often that's negotiated between the sponsor and the FDA. I will say that there have been VAERS reports from clinical trials. It's rare, so every now and then we'll get reports for a vaccine that are dated prior to when the FDA actually gave the licensure, and so we assume those are from clinical trials. But I don't. If there was a VAERS reporting requirement, it would have been written into the protocol for the clinical trial. But typically that, I don't believe, is part of a clinical trial, because the safety monitoring for clinical trials is so intense and so controlled, and is usually done by this thing called a data safety monitoring board. So there's a lot of activities that go into safety monitoring besides spontaneous reporting to VAERS. That said, it has happened in the past.
Okay.
Yeah.
I'm going to ask the staff to unmute the line of pharmacist Rashid Abdo. Rashid Abdo has a question for Dr. Kublin. Okay, it must be a muting issue, so I'll Dr. Kublin, just very briefly, we don't have time to get into this in any depth. You mentioned 3 vaccine platforms. Could you just highlight again the differences between those 3 platforms, those 3 vaccine platforms?
Sure. The first and the first one out the gate here is a nucleic acid-based platform that's either DNA or RNA. And these are first off into the clinic because they're very fast to make. I think, you know, it was within 2 weeks after the sequence of the spike protein was made available that some of this material was made. That cannot be done with some of the other types and platforms of vaccines. The second is the adenovirus vector platform. And we're looking at 2 different platforms, one developed at Oxford University and the other developed by Janssen, which is an Ad26 platform. And that delivers a piece of the virus so that your immune system can recognize that piece of the virus such that if subsequently exposed, they're protected. And the last is the standard, more typical protein and adjuvant. Now, what is unique across all 3 of these platforms is that they're all targeting this envelope spike protein. So we may have a tremendous opportunity to, again, look at those correlates of protection, which hopefully may be very similar across these 3 platforms.
Okay. Next question, Tamara Fox. Tamara Fox, we're going to unmute your line. Okay, we seem to have more technical difficulties today. I apologize for that, folks. The question is there a way to determine if clinical trial is available locally? So what would the patient need to do? Could you give us, you know, is there information in the material that APhA is reposting for you that would help pharmacists be able to address those questions? And then how do we know if there is actually a clinical trial that's ongoing or enrolling patients near our current locations?
Now, this is a great question and a huge challenge for us, honestly, because of how rapidly we're moving. And so many of these, now over 300,000 participants in the registry, want to know, when are they going to get in? Where is the site? Where can they go to enroll into the study? We're not making that publicly available at this point in time because it is constantly changing. We are adding new sites all the time. Now, there may be an opportunity in the coming weeks or months to list those that have been activated. But as you can imagine, there's a tremendous amount of sensitivity as well with regard to what sites are selected, why some are selected, why some may not be selected. Most importantly, the clinical trial sites that are selected and are actively enrolling participants, they have access to those participants in their catchment zone, in the zip codes that they've provided that are in their recruitment area, and they are reaching out to these participants now.
Okay.
We will have further communication with people in the registry about the status of these clinical trials. We want to make sure that people are informed who have given that information to us about them in the registry. So we do intend to have further communications to them and updates that we'll provide. As I mentioned, you know, with 5 clinical trials, 300,000 each, that's 150,000 people. And I'm asked, well, you've got 350,000 in the registry, why would you want any more? The reason we need probably millions in the registry is because we need those demographic factors. We need people who are at risk of being infected, and they will be targeted for the recruitment into the registry. Then I'm asked, why should I enroll? I'm at low risk. The reason we need a whole spectrum of people across diversity, occupations, etc. We're providing the risk scores for people in the registry, and it's best to have a large number, literally millions, of people in the registry across all of the diversity of responses that you'll see once you register.
Okay, well, the next question that we've gotten is if a person enrolls in a clinical trial and they, at the end of the trial, turns out they received placebo and did not receive active vaccine, and the vaccine shows that it does in fact work, will those individuals be offered vaccine? Are they guaranteed that they'll be offered vaccine?
They will be given the vaccine if it is effective. Their time and effort as a study participant will guarantee them access to the vaccine. Absolutely. We've had that discussion extensively with every developer. They will be given the vaccine if it is found to be effective. And you know, it's one reason to participate in these clinical trials, but it would, you know, we're hoping that it won't be too many months later that we be deploying that nationally, and in large part through the tremendous relationships that all of you have as pharmacists with your respective communities.
Yeah. Okay, I'm going to just ask one last question on this topic, and then we're going to have to move on with our program. I've got literally dozens of questions that have come in. We just don't have time to answer all of them, and I apologize to our participants that we can't get to every question today. This has been a hot topic, needless to say. Relative to COVID vaccine coming, we hear a lot in the news about the fact that COVID vaccine is going to likely come to market, and at the same time, pharmacists are actively giving flu vaccine. Is there anything going on with the clinical trials regarding co-administration of flu vaccine and COVID vaccine? Anything that we need to be aware of there? And, you know, should, at this point, what's your recommendation? Should pharmacists be thinking, yeah, maybe giving these two vaccines together? And again,
That's a great.
we've just got a couple of minutes, so if you could just give us a answer.
Very quickly then, some of the protocols specify you cannot receive a vaccine for 28 days before or 28 days after. Now, some of them do not specify that. I think most investigators for clinical trials don't want to co-administer the vaccines within a few days, maybe even a week. We're trying to really activate the immune system against SARS-CoV-2 virus, not the flu virus in this case. We're hypothesizing that the flu season may be much milder this year because of all of the precautions that people are taking. But we're very confident that when an effective vaccine is identified, we'll be looking at co-administration to make sure there's no deleterious interaction, and presenting on that as well. But the recommendation will likely be space them out a couple weeks to make sure that without that clear evidence of no interaction, we're giving them it in separate intervals.
Okay, all right. Well,
and I'd also say if there are other questions, I'd be happy to answer them by email, and we'll do so in working with you, Michael.
Well, we'll make sure that you get a copy of the questions that we've gotten from our listeners, and all of you can participate at APHA's Pharmacists.com Engage platform, where our COVID-19 community, you can ask questions and share information, and we'll do our best to try to post answers to additional questions that we received from both of our speakers. Tom, Jim, thanks for both of you joining us today. We appreciate it. And now I'm going to call on Mike Baxter to join us to talk about late breaking news from this morning. Mike, I wonder if you would first share with us what happened this morning, and let's talk about that first before we talk about the pediatric immunization issue.
Sure. If we can go down 2 slides. Okay, thank you, Brian. So just to let everybody know, this morning, actually, we found out, it's actually posted yesterday, that the administration came out with kind of a web posting on the HHS website stating that they're going to actually rescind the existing guidance that was issued by the FDA to make sure that the tests that are out there for COVID-19, whether they're serology tests or diagnostic tests, have to be basically approved by the FDA. They have to have an emergency use authorization. The FDA actually pulled about 27 faulty serology tests that were on the market using this authority before. So they really stepped it up and kind of made it a priority that the manufacturers would apply within 10 days to actually get this authorization. Well, it seems from this posting on the White House's website for HHS that they unilaterally acted, and they didn't even consult the FDA staff before doing this. So that's a major concern for us, for pharmacists included in serology testing and also diagnostic testing for COVID-19, that if you have a relationship right now with a lab, or if you want to set one up, they may not have a test that has an EUA or that is authorized by FDA. The concern there, and you can see on the right-hand side, the quote that was posted on the HHS website, is that you're going to lose the liability coverage, the federal liability coverage under the PrEP Act that comes with doing an FDA authorized test that has an EUA. So there's a lot of concern there for our members. So wanted to make everybody aware, just breaking news, that you should be aware that if you're partnering with a laboratory, that you may not have this liability coverage. And we're recommending that our members only partner with labs currently that have that FDA or EUA authorized protection so that they can be liability protected.
Yeah, so Mike, I just want to reiterate this to our listeners so that everybody's hearing this clearly. Because of unilateral action that the White House has taken today, there could potentially be COVID-19 tests on the market that do not have EUA approval. And if a pharmacist is involved in collecting specimens related to that test or conducting the test, you will not be covered under the PrEP Act liability coverage. Did I get that correct? That's exactly what you're saying?
Yes, that's our assumption in the clear reading that you can see on their website. We've followed up per the FDA because the FDA referred us to the White House and HHS. So we have followed up and expressed our concerns, and we're waiting on a reply.
So, APhA will work very closely with NASPA, our state association, affiliates, and other pharmacy associations to try to get the news out and information out about this late breaking news to pharmacists throughout the day today and into the weekend. Please share this information with your colleagues. It's very important to know. Now, I also just briefly, and we won't ask questions about this one, Mike, we'll just let you share with us news that probably some have saw or have been aware of on social media yesterday related to pediatric immunizations. What happened yesterday?
Sure, yeah, just really quickly, if you follow us on social media, saw we had a big win yesterday for pharmacists. Now there's federal authorization. It's a good thing for the administration, where they have federal authorization now under the PrEP Act during the public health emergency to administer childhood vaccines that are ACIP recommended. So all the vaccines that are recommended by FDA right now, you're allowed to administer those for ages 3 to 18 right now. You can see some of the requirements on the slide for today. So a big step forward for us. Also for pharmacy interns as well, under pharmacist supervision, can do this. You'll see, obviously, there's a lot of requirements there. There's the VAERS reporting that was mentioned by Tom before. You'll see as well, there's also inquiring about whether there's a well child visit that had been made with a pediatrician as well. So there's a number of other things there too. Important thing to mention is if your state has laws that let you do more, this does not preempt state laws that let you do more. So if you have state laws that are allowing you right now to even immunize below age 3, you can still do that. So that's another important factor to put out there. But major step forward and a major role that pharmacists can play now in dealing with immunizations. They did not address reimbursement though. So reimbursement, we always talk about, this is through your states and through your Medicaid programs, but this is certainly a big tool in the tool belt that you can go to your states and say, well, we're authorized, we can do it. Now, how are we going to get reimbursed?
Yeah, so for pharmacists, the advice that we would give you at APhA is that if you're interested in providing pediatric immunizations through your pharmacy practice, be in touch with your state's Vaccines for Children's program, the VFC program, to see if your state will authorize you as a VFC provider. That is a program that allows pediatric patients to receive vaccines at no cost to the individual patient. There are some requirements and restrictions around that, so not a decision you should make lightly by any means. And you should also consult with your state Medicaid agency regarding whether or not they have a payment mechanism in place to pay you for conducting these pediatric immunizations. And a large portion of immunizations given to pediatric patients do happen through either the VFC or Medicaid programs, not exclusively, but a large portion. So, Mike, thanks for sharing this information with us.
Sure.
And I'll share with our listeners that we still have our educational series COVID-15 on 19 available for you to be able to peruse and to get CE on hot topics related to COVID-19. And we also have a number of practice resources. We have updated our practice resource related to COVID-19 fraud and scams that are out there. You should look at that because you need to be a wise consumer in addition to being a wise provider, because there are lots of scams going on out there. So be sure to consult that resource as well. In addition, as I mentioned before, we offer a benefit to APhA members to be able to network together through our Engage platform. This is the opportunity for pharmacists to share ideas and practice trends with each other. The Engage platform has been a wonderful tool for many pharmacists to be able to get ideas on how to approach different things. We've had so much information this week just about vaccine safety. I wish we had another hour to talk more about that. And I'm hoping this will seed a conversation on pharmacists.com on the Engage platform for COVID-19, that you all will have conversations about safety and put out there your concerns. Now, before we end the webinar, I'm going to do a polling question, and I know I've taken the staff completely off guard by doing this. Do you personally plan on receiving a COVID-19 vaccine when it becomes available? This is asking whether you, as a pharmacist, plan on receiving a COVID-19 vaccine. Is your answer yes? As soon as I can get one, I'm going to take the COVID vaccine. Yes, but only after I have a little bit more information about vaccine before I take it. No, I'm not going to take a COVID vaccine, or I'm undecided. I just don't know what I'm going to do at this point. We want to get your opinions about this and see where you stand. And we've gotten good response so far. Let's see if we can get it up just a couple more percent. Okay, let's show our audience what the response is here. So, you know, it looks like that vast majority of you, what does this come up to? I'm doing math on the fly. This is a high risk situation for me, but over 80% of you plan to take the vaccine either immediately or as soon as more information is available. Another 13% are undecided, and 4% of you have said, no, I'm not going to take the vaccine. Now, I want to share with you all that life is very sometimes difficult, and we get stressed out, and pharmacists have maybe too many things on their plate. Folks, don't forget to enjoy what you do every day. Take a deep breath. Be sure to remember that the journey is worth it, that our patients are worth it. You all know that. I just want to encourage you that the work you're doing is so critical. Next time we get together next week, we're about 6 months and some into this COVID pandemic. We're going to kind of cover next week where we are with the pandemic, where we are statistically, where we are with drug therapy. We're going to do a broad overview program for you next week so that we can kind of reset and see 6 months in, where is our country with COVID-19. So I think it'll be a great conversation for us to have next week. In the meantime, thank you for all that you do for our profession. Thank you for everything that you do for your communities. Have a great week, and God bless.